Just by sheer definition of capitated risk means that there is an endpoint and a threshold we have to stay under in terms of total cost of care for drugs. And so drugs being the biggest bucket, and the one part where I think there's a big debate as to can we actually control the cost of drugs, by being the owner of that category, just by sheer definition, we're actually providing value to that biggest bucket of cost for any value-based care model. So whether it's the payer or the provider, we're actually giving that the ability to control drug costs without actually jeopardizing any sort of outcomes for the patient. That's the dilemma that we've actually been able to solve for the payer as well as for the provider. We're actually aligned with that. I think that that is the future of how you can actually manage drug costs and keep accountability with still being able to maintain the ability to prescribe products as needed for the patient, right? It's all about going back to giving the right drug to the right patient at the right time. And I think pathways pretty much take out the guesswork out of that, which is great. And I believe the article mentioned about an 80% adherence metric, which is about standard. Most pathway adherence rests between 80 and 85, which is what we see as well. In fact, that's one of the things that we're advocating for, is really paying attention to the adherence metric. It's not enough to have pathways. You have to have accountability with those pathways to make them meaningful and to have a meaningful outcome from the use of pathways. So putting an adherence metric around that, I think, is the right way to go. So absolutely aligned and agree with what the authors of that article have put forth.